Ladies and gentlemen, please welcome back Lori Fogelman.
And we welcome all of you back again for our final panel discussion today, this time on the healthcare industry. And let me introduce to you our distinguished panelists who are here for the healthcare industry panel discussion, and we will begin with Joel Allison. Mr. Allison is Chief Executive Officer of Baylor Scott & White Health. His primary responsibility is to help Baylor Scott & White attain its vision to be the most trusted name in giving and receiving safe, quality, compassionate health care. Mr. Allison's career includes more than 4 decades in healthcare management. He joined Baylor Healthcare System in 1993 and served as Baylor's Senior Executive Vice President and Chief Operating Officer before being promoted to President and CEO in 2000. In 2013, he was named Chief Executive Officer of Baylor Scott & White Health. Mr. Allison is a fellow of the American College of Healthcare Executives. He received a bachelor's degree in journalism and religion from Baylor University in 1970, a master's degree in healthcare administration from Trinity University, and is a graduate of the Harvard Business School Advanced Management Program. Next is John Foster. Mr. Foster is president for the American Group of Nashville, Tennessee-based HCA, and HCA is the nation's leading provider of healthcare services. He's responsible for 80 of HCA's hospital operations. Prior to his current role, Mr. Foster served as president of the HCA Central and West Texas Division. He joined HCA in March 2001 when he was appointed president and CEO of St. David's Healthcare in Austin, Texas. He has served in various executive capacities with Baptist Health System in Knoxville and the Methodist Health System in Houston. Mr. Foster also has served on a number of national and state-level governing boards, including most recently as chairman of the Texas Hospital Association Board. And finally, Laura Irvin. In January 2014, Ms. Irvin was named Executive Vice President for Integration and Alignment for Methodist Health System. She initially joined Methodist Health System in 1996 as an administrative resident at Methodist Dallas Medical Center. In just 3 short years, she advanced to Vice President of Methodist Charlton Medical Center. She later became Senior Vice President of Planning and Marketing for Methodist Health System, President of Methodist Mansfield Medical Center, and in 2011, President of Methodist Dallas Medical Center. Irvin has been recognized by several professional organizations with awards such as the inaugural Young Healthcare Executive of the Year given by the Dallas-Fort Worth Hospital Council. Furthermore, Methodist and Ms. Irvin were honored as 100 Leaders of Great Hospitals and in the 2012 and 2013 lists of Women Hospital and Health System Leaders to Know. And that was by Becker's Hospital Review. Ms. Irvin holds a bachelor's degree in business administration from Baylor University and a master's degree in healthcare administration from Trinity University. Today's conversation will be moderated by Baylor Provost and Executive Vice President, Dr. Ed Trevathan. Dr. Trevathan began his tenure here as Baylor's Chief Executive Officer in June of this year. He earned degrees from Lipscomb University, Rollins School of Public Health at Emory University, and his medical degree from Emory School of Medicine. He completed residencies and postdoctoral fellowships at Yale New Haven Medical Center, Yale School of Medicine, and Massachusetts General Hospital and Boston Children's Hospital, Harvard Medical School. After serving as an epidemic intelligence service officer at the Centers for Disease Control and Prevention, Dr. Trevathan held faculty appointments at Emory, University of Kentucky, and then at Washington University in St. Louis. A practicing pediatric neurologist, he also served as neurologist in chief at St. Louis Children's Hospital. Dr. Trevathan has served on a variety of committees at the National Institutes of Health, the CDC, the Institute of Medicine, and the World Health Organization that impact child health, maternal health, and neurological disorders. While at CDC, he served as the strategic lead for pediatric response to the 2009 H1N1 flu epidemic. Please join me in welcoming Dr. Trevathan and our distinguished panelists.
Well, this is an exciting time to be in leadership in healthcare, and one reason is because the challenges and the questions facing leaders are really quite difficult. Many of them don't have straightforward answers, but I think listening to our leaders here speak and think today will give us some insights that may be new to many of us. Let's begin with one that's pertinent, I think, to many of us, and that is over the last few years, as all of you know, there's been an increasing number of mergers between and among healthcare systems. So what do you believe, based on your experience, are the forces behind these trends, and can we expect this trend to continue?
You want me to start?
Go ahead. Sure.
I think so. While the number of mergers is still higher in 2015 than it has been in recent years, it's started to plateau and percentages decline in 13 and 14. But the causes for mergers is, I think, driven by systems wanting to work together, align across geographies, and help bring the infrastructure together that's needed that can be harder for smaller systems sometimes to do on their own. And you need a lot of IT infrastructure, sharing and alignment across multiple types of providers, and multiple systems will find themselves in an inability situation to provide that. But I think what will continue in addition to mergers is more alignment across geographies. Methodist, Baylor, Scott and White, and the Dallas area have aligned across some geographies and different networks. And that is a productive financial way to share quality data, connect in resources without going through asset purchase and facility situations.
You know, maybe just adding a little color to that too. When you think about hospitals across the United States, there are roughly 5,000 hospitals in the U.S. And I read a study not long ago that said that fully 1/3 of those lose money, another third of those break even, and the other third of those are on solid financial footing. When you add that sort of financial complexity on top of the fact that they operate within a highly regulated environment that's very capital intensive and very human resource intensive, that the stakes just to be able to be competitive anymore are far higher than they have ever been in the past. You've got health insurance consolidation that's applying pressures, and a lot of different competitive forces that are causing really a situation, I think, in the hospital sector today of the haves and the have-nots. And sometimes those are based on sort of urban versus rural. Sometimes, those are just based on where they're positioned. Sometimes it's just, how they're managed and the situations that they have. So I think all those forces together are driving more merger and acquisition activity. But I think Laura's right. You're seeing an emerging trend about more affiliations, more joint ventures, more other, sort of contractual relationships that aren't necessarily just pure M&A like they have been in the past.
First of all, Ed, I want to say thank you to Baylor University and to Dean Maness for inviting me to be a part of this illustrious panel. These are great colleagues and great friends, and I want to thank you for the honor of being here. And I also want to say thank you to Paul Foster and his family for making this beautiful facility available, and all the contributors who made that possible. And my good friend Bill Robbins, Mary Jo, thank you for the Robbins Institute. You heard all three Baylor graduates, all three went to Trinity. Well, that was because when we were at Baylor, I know when I was here, there wasn't a Robbins Institute to go to. In fact, if you wanted to go to a Baylor degree in healthcare administration, you had to join the Army. And so I didn't do that. I didn't do that. And then the second thing was I saw Dean Maness, and I said, this is so fabulous and beautiful. I said, I really would like to come back and get another master's here, because this is state of the art. He said, Joel, don't worry. He said, you couldn't pass the admission test today. So I'm glad I got in when I did and got it out. But just to add to what my colleagues have said, and they've hit the nail on the head, the Affordable Care Act, when it was passed, obviously began the discussion around where do you go, scale, and the merger and transactions began to occur. Last year there were 100 of such mergers and acquisitions, which was the highest in several years. Through August, we've already had 7. I don't see it slowing down. And obviously, we represent one of the major mergers that occurred over the last 3 years. In October 1, we'll be 2 years old, October 1 next week, of Baylor, Scott and White. The interesting thing about these mergers, as Laura pointed out, was a lot of it has been when people get in difficulty. There's a third of our hospitals, and we've seen some hospitals kind of go out looking for a partner because they don't have the capital to invest in the new technology, the new science, to attract the type of medical talent that you need. So that occurs. For us, we looked at it as not a financial transaction as much as a clinical transaction, because we felt like we could help transform how healthcare is delivered in this country to change the model. A lot driven by the Affordable Care Act, moving towards more of the prevention and wellness. So I think you're going to see these hospitals, John's right, there's going to be a lot of them that will go out of business. We're seeing it today. And if they can't find a partner in some fashion, they're going to have struggles in order to be in these networks that we've talked about.
Well, many of the rural communities in our state and around the country actually have worse health outcomes than similar populations in urban areas. And so given the pressures you're describing and the tendencies for mergers, I know a lot of that's going on in urban areas. How difficult is it now for hospitals in rural areas serving health systems involved in rural areas to survive in this environment? And what can be done really to sort of strengthen rural health care?
Well, I think one of the things you've got to look at is they've got to change the model. Unfortunately, not every community can have a full-service hospital. It's just not possible. And some of these rural hospitals will need to connect. And I think the future is looking at the model of how do you redesign it. You look at having maybe some clinic, emergency room. And now that we have telemedicine and telehealth, I think there's a lot of ways to connect so that you can then have some care in that community. But what they have to do is what we all have to do is look at what is the needs of those communities. And they're not going to have some of the high-level service because they can't basically afford the talent or the technology, but they can align, and I'm encouraged by the opportunities to work. We had 11 rural hospitals in Texas close last year, and we're afraid we're going to see more. But if they can work with a large network, and again, looking at your geographic distribution, and have some connectivity and working with physicians and telemedicine, robots, things of that nature, I think we can preserve some services, emergency services. Can you deploy transportation so that they can get upstream for a serious, but they have somebody to stabilize them in a emergency room outpatient clinic?
Agree with Joel. We see around the United States the closing of hospitals in rural markets, and it is, I think, a very difficult situation for small communities. Oftentimes, hospitals in a small community are the major employer, and so to think about scaling that back dramatically and having a very different model is very hard for them to do. I think Joel is right. I think what you're going to see evolve are access to sort of very time-sensitive services, emergency department services, outpatient services, things along that line, but a greater concentration of the more specialized services happening in the urban markets. I just think that's how that's going to have to go from an economic perspective. And I think there's a quality imperative around that as well. Studies show that low-volume providers of services tend often to not have the same level of quality as higher volume providers do. And so that's a tough transition that's going to occur, but I think it's going to have to.
Agree, and I think the technology that's available to connect rural facilities, share healthcare data, will give reassurances to patients and providers in those communities on how transitional their care can be as they need to move specialty services toward more urban areas. And then primary care is so much different than a traditional doctor's office, and urgent care, telemedicine, as Joel and John mentioned. So placing the right type of access points with the right type of IT intelligence, I think, can make it more palatable and for some of the rural communities on how well they're able to access most of the care they're going to need on a regular basis.
Well, one of the challenges that many of us in the room, I know we have quite a few healthcare providers here and health administration leaders. We've seen this transition over the last many years, couple of decades especially, moving from more of a fee-for-service system into value-based reimbursement. Where do you all think the future of payment reform is going? What can healthcare administrators see, and what do you think they're going to see in the future? What are the future challenges?
Well, I would say that fee-for-service medicine and value-based reimbursement are not necessarily mutually exclusive. You see the blending of the two very dramatically happening right now. More and more of the reimbursement that we receive as providers has a connection or some at-risk component for clinical outcomes and service outcomes and things like that. Medicare has gone on record and said for the $600 billion that they spend every year, that they want to fully see 50% of those payments be tied to some sort of value-based formula by 2017. There are going to be a lot of models that are out there about how providers sort of deal with that. I think it's the right way to go. I think it's an accountable position that we need to take with the communities that we serve. And I think provided that the incentives are what they ought to be around that, so oftentimes you see certain structures and certain formulas in certain contracts where it's highly punitive and it doesn't create the incentives that you want to really see to try to drive that across the industry. But if Medicare is doing it, clearly more and more private insurance companies and private industry is going to be doing that. They'll follow right along with that. Have a lot of pilots going on throughout our 42 markets across HCA that are trying different methods and different models on how to best treat patients under those kinds of reimbursement approaches.
I would just add a couple of things. One, as I look back over the years, one of the things I've felt that's always been broken in healthcare is the financing of healthcare. I don't think we finance healthcare correctly. It's got to change. So whatever that model is, as John said, you're going to have some fee-for-service, you'll have value-based. We have to get on the other side of this to where the incentive is around keeping people well and healthy and be recognized for the quality that's delivered, as opposed to just waiting until it gets into the acute care setting and it's much more expensive. So we have to deal with the reimbursement because the trajectory we've been on has not been sustainable. It's not sustainable to the government as 10,000 baby boomers, all of us rolling off us, me, I may be the only baby boomer, I'm the old man in the room, but 10,000 a day, and that's going to continue for several years. You've got the cost of pharmaceuticals, everything is going up and up, and you cannot continue, it's not sustainable for employers. We need for them to stay in the insurance programs in the game to help deal with the shortfalls we have on the other side that we're not getting recognized for. And when you look at it, if we don't do that, it's not sustainable for the individual. And so we've got to find a way to remove the barriers that keep you from going to a value-based and be recognized for quality and safety and keeping people well and healthy. If you incentivize it that way, I believe, in all honesty, you'll create these new delivery systems that will recognize that. And John's right. Medicare's moving there rapidly. Actually, in that, I think, John, 18, it's going to be 90% on value-based.
Moving at 90%.
And we're already there. They're talking bundles. They're talking about shared savings. Medicare has a shared savings program. So all of this is going to, and now all the commercial will follow it. We need to be ahead of that because we're the ones that can really change the reimbursement.
The only thing I would add is I think for value-based payment, in addition to improving health and overall health of the population, as John and Joel mentioned, is receiving the right care at the right time and utilization. So moving away from volume-based payment. And a lot of our chronic healthcare conditions, you may have a CT multiple times because different points of care don't talk to each other. There isn't the sharing of the records and the data. Doctor's offices are closed or access points are closed, so you go into the ED, and so you're hitting some of the most expensive ways to utilize healthcare more frequently than you need to. And all of us agreeing on prices with payers and employers and managing that sharing value payments and potentially risk together helps all the providers align and work together to make sure that not only are we improving health, but we're helping all these patients receive their care when they should receive it in the right location.
So when we talk about payment reform sort of at the health system level, not just at the individual practitioner level, are there ways that payment reform could further impact community level health in terms of driving behavior change, for example, that can lead to health, community-based interventions? Have we started to see any of that, you think, in terms of some of our reimbursement systems? If so, share that.
Well, I'll share an example from what Baylor, Scott & White's doing, and Laura referred to it earlier. We have really an integrated delivery network, which means not only do we have the providers, the facilities, the physicians, other providers, but we have a health plan for the financing, and we have a quality alliance, which is our accountable care organization.
Right.
And the whole concept of that is to really be able to manage the patient in a population health management strategy. We have gone, as some people say, all in on population health management. What does that mean? It's basically three components. It's getting everyone to a patient-centered medical home. Part of this has been the misuse of EDs, it's lack of having a physician. So all the patients within our quality alliance that we are accountable for have a patient-centered medical home. You have to do care management. We have not done care management. Healthcare has been one of the most fragmented industries. There's never been a coordination of care. You may have a primary care doctor, you may have this specialist, you may go to this specialist, but nobody's quarterbacking your care as I look at it. And then the third piece is that you manage the chronic illnesses, and you have to have the data, big data to do that. And that's what drives this 5% that uses 50% of the healthcare dollar. I mean, we're spending $3 trillion a day on healthcare. There's enough money being spent in healthcare today to cover everybody in this country. We just don't do it right. And that's what we're trying to achieve with population health management, using our physicians, our mid-levels, to manage the care so that we can take that risk and be recognized for the high quality and doing the care coordination. That, to me, is how we move, and that's what the Baylor, Scott & White Quality Alliance is about in our network that is also, Methodist is in that same network.
You know, Joel's right. And, you know, hats off to the Baylor, Scott & White system for being able to assemble that kind of a powerful system. The challenge that I see is that's very hard to scale across the entire United States. We just got done talking about a third of the hospitals are losing money, a third of the hospitals are breaking even, and another third are on solid financial footings. And so when you think about, you know, that kind of model and the level of investment, capital that has taken to get to that point, I think in communities where you have very strong health systems, that is something that you can look forward to probably seeing. I think that's really hard to scale. The other thing that I've seen that's a little bit hard to get your mind around is that payment reform would actually drive a different set of health decisions. What we often see is that payment reform changes the cost curve a bit on how people utilize care. Yeah. But what greater incentive could an individual have than not to get cancer, not to get heart disease, not to get diabetes, that $1,000 increased copay or this or that other, you know, is somehow going to be a substitute for. And so we've seen many models across the United States where there's payment reform, but there is not behavioral change that really ultimately affects the health of a population. So I think we're early in this. I think we're going to be partnered in this to try to get this done, but it's really hard to envision that being scaled in every community across the United States.
No, and I agree with John. Scale is going to be important. How do you do it? But if you can get enough of the networks doing that with that model, then perhaps you can say it, because I agree 100%. If we don't change individual behavior, we're not going to be able to achieve what we need to do. There's got to be a lot of individual accountability about his or her own health. And the other thing about the payment reform, and now you have the exchanges, what we're finding, we used to be worried about people getting insurance. Now, having insurance does not guarantee you access. We all know that. But we have more people now getting insurance, but now that they're insured, sometimes they can't afford the health care because of the deductibles. $6,500 for someone on a middle income going into the hospital and saying, well, you got a deductible and you got to satisfy that before you're covered, is going to be very hard. Sure. And so there's got to be more to it than just saying this is the way that we're going to change the payment.
Right.
And I think, as Joel and John said, I think where we're focused is we've begun over the last several years in healthcare to focus on population health management. Everyone's starting and focus on the tip of the triangle, the sickest chronic patient. But as we start to evolve, and I think employers are starting to find incentives, certainly self-insured employers, on how do they help their employees at the bottom of the pyramid not move into the sick population? How do we help prevent some of the chronic diseases? And so I know a lot of us, Methodist is an example, a lot of large healthcare systems that are self-insured, starting with our own employee population, wellness programs, and starting slow, offering financial rewards, and then slowly getting toward tiered programs based on biometric screenings on how much you're paying for your healthcare, how much is your deductible copay that's coming out of your paycheck based on biometric screenings. So to incentivize the behaviors that will, over time, help less patients move into the chronic category.
So one of the problems that is facing many healthcare leaders, certainly in Texas and many other states, is exemplified by the fact Texas is one of the states that has not expanded Medicaid to low-income adults under the Affordable Care Act. And some current estimates that I've seen are that Texas will lose about $100 billion in federal funds over the next decade or so, and Texas hospitals are going to absorb about $5.5 billion per year to treat uninsured patients as a result of the opposition to the ACA component of expansion of Medicaid. So how does this opposition to Medicaid expansion in Texas, and John can speak to how this plays out in Tennessee and other parts of the country, affect the financial viability of some of our Texas hospitals and health systems? And then how does this impact the health of Texans, in your opinion?
Well, let's put it in a little bit of context. So we have, roughly 27 million people that live in Texas. Of those, we have 5 million that are uninsured, roughly 19 to 20%. And that is a very significant burden, certainly on the hospital systems in Texas. But it's also creates a scenario where people without insurance tend to forego or defer preventative care. They tend to oftentimes not be able to afford their medications that they might need for chronic conditions, and then they forego or delay that. And what ultimately happens is those particular health challenges tend to wash up on the shores of our emergency departments. And so, of the 5 million uninsured, they tend to seek care in our ERs, and that is certainly not the lowest cost place to be getting care. The 5 million uninsured in Texas are largely the working poor who don't make enough to be able to afford private insurance, but make too much to qualify for Medicaid, and so they fall in this gap. Obviously, Baylor, Scott and White, and Methodist, they're great partners in the provision of free care to people that come to our hospitals. And for HCA alone, in Texas last year, the cost of providing free care to our patients was $700 million. And so that is a very big cost burden on our system that largely is fed through the emergency rooms, of which there were 2 million ER visits across Texas in HCA hospitals last year. So it definitely affects the health of Texans. It definitely is a cost burden for the providers. And anything that we might be able to do around getting more people insured will lessen that burden and hopefully create a system where we can give people better access to care than just the ERs, which really is not the most effective way to do that. One last point, in states that have expanded Medicaid, and we see this across our company, you've seen a dramatic decline in the number of uninsured. And now I think it's a little early read to say there's also been a dramatic increase in the health of those populations because there's so many things go into that. But we certainly see a corollary there in our other markets that have expanded.
It's very interesting.
Could I just add one thing on that? Laura's in my market, it's more like 25% uninsured because
Wow.
just the population that we have there. And to John's point, it's also a hidden tax on employers and the individual. We're just shifting that. There's no care not paid for. It's a hidden tax and the burden. And what was interesting, when the Affordable Care Act came out, Billy Hamilton was the state economist, did a study and recommended, from an economic standpoint overall, it was the right thing for Texas to expand Medicaid. It was proven to be the right thing because of our high rate of uninsured and what it would have done for our state. Because even under the expansion, remember, the undocumented workers are not included. So we still see those. We do about $600 million of community service. And I know Laura does the same. We're in the trauma network. We get a lot of these. So finding a way to get more people covered is what we've been about, because the state refuses to expand Medicaid. So it is a concern, it is a burden. It is something we have to deal with, and we continue to find how we do it. We use 1115 Medicaid waiver, which you don't want to hear about. It's way too detailed. But that's how we have substituted the expansion of Medicaid.
You know, and I think you would agree, you see this in your own ERs. What if you had to run an organization where 1 out of every 3 people that came into your emergency rooms, you had to give them the merchandise or the service for free? That's the situation that hospitals have. Yeah, we may have 20% uninsured, but of the ER visits that occur in our ERs across the state, 1 of every 3 comes in without resources. And that's a very difficult challenge.
Well, as I was listening to you all explain this, this is obviously, this one conversation could probably go on for an hour, and we have 13 minutes and 32 seconds. But it occurs to me that we really haven't, as health leaders, and I think as public health leaders nationally, we haven't done a great job, this is my opinion, in explaining this to people, what you guys have just talked about. I'm reminded of a study that was done in Missouri a couple of years ago, in which a representative sample of Missourians polled. 90% supported every major component of the Affordable Care Act when they weren't told it was part of the Affordable Care Act. But then when asked if they supported the Affordable Care Act, about 80% opposed it. So, and this is part of the reality that hospitals and politicians and business leaders are dealing with. What can we do as business leaders, healthcare leaders, what can we do to better communicate the realities that you all have discussed to the general population?
A couple of comments. First, we've got to have an audience that'll listen to us and let not be confused by facts. Never let that be the problem. But seriously, I think the business community has to be the ones to lead this. And what's interesting is almost every major chamber, the Texas Business Leadership Council, and in Dallas, the Dallas Citizens Council, all endorsed expansion of coverage in Texas. So we have to continue. The best message to get to Austin, quite frankly, Ed, is from the business community. And that's what it's going to take, I believe, to get this further down the road. But we've got to have a receptive audience.
Yeah.
Agree.
I agree. It shouldn't be a social political issue. It's a social health issue.
Yeah.
And I think one thing that is, if you ask physicians, certainly, that can get real passionate around what's good about American healthcare. And one thing that is good is access and how Americans want to pull together to offer more to others. But sometimes that gets involved in the political system because of the government payers involved in our business. And so we have to be able to separate the two and do what's best for those who can't provide for themselves.
Yeah. So you heard it first here. It's the business leaders that need to be talking about this. So a number of years ago, Texas took the lead, actually, and enacted some malpractice reform. So has that reform had a positive or negative effect on the impact of quality of care provided in Texas hospitals. And what are your all's thoughts about that and what may or may not need to be done in the future?
Well, I was very much involved with that. I think it's been great. Tort reform was very helpful, and I appreciate what the legislature did to enact tort reform, because we were literally losing doctors out of Texas. Yes. We had facilities losing services. They weren't going to cover trauma because of the high cost. The doctors couldn't afford the malpractice. We were losing trauma surgeons, neurosurgeons, OB, high risk. And it was a real difficult time, and we were losing people. That has changed now to where people are coming to Texas because now they can afford the coverage. They can come back and practice and not be constantly threatened by huge inappropriate lawsuits. And so I think it's been very positive, and it's something that allowed us to continue to offer some very needed community services. I got amused last Saturday. I was speaking to the New York Healthcare Trustees Association, and they wanted to know about our models. And I never will forget, I talked about Baylor, Scott, and White. Anyway, one of the persons standing up, he said, now, as you all have created this, how did you deal with tort reform? How did you deal with lawsuits? And how did you deal with unions? And I said, well, I'm glad you asked that, because that's why I'm going back to Texas. We're open for business because we do have tort reform, and we don't have unions. We're a union-free environment. We're a right-to-work state, and that will keep us able to even meet the needs of this community that we serve, even with this uninsured population. Those are two big costs.
You know, we have in Texas, I believe it's right, we rank 41st out of 50 states in the number of physicians per our population on a per capita basis. And so tort reform has been very helpful. Joel's right in that regard, but we still have a physician shortage in this state, and that is largely because we do not have enough postgraduate medical residency slots available to train physicians in this state. So we haven't added a medical school in quite a while. We're now adding some medical schools around the state. We need additional residency slots because obviously studies have shown where you train tends to be where you stay. And tort reform has been great for us, but it's certainly not enough in dealing with, I think, the imbalance that we have across the state in terms of physician supply. The tort reform change for us was particularly strongly felt in South Texas for us. We have hospitals in McAllen, we have hospitals in Brownsville, Corpus, El Paso, and those were areas that were difficult to recruit to anyway. And then they were also areas that were very litigious from a malpractice environment perspective. And you just flat couldn't get doctors to come there. And so it's a real challenge that was, I think, alleviated, and we're seeing much more success there these days. It's been good.
Agree with everything they said. It's been most helpful for the safety net, trauma hospitals, for the specialties that are you're most involved in life-saving, neurosurgery, trauma surgery, high-risk OB. And as Joel mentioned, we've been a trauma hospital, safety net hospital for decades. In the 90s, we almost had to shut down our trauma service because we had neurosurgeons leaving the state, going to Florida. So it took even years after tort reform passed, as John mentioned, for newly trained physicians to want to come to Texas and work. And we're probably the last 7 to 10 years have really helped resupply many needed specialties in Texas.
So over the last few years, not-for-profit and for-profit healthcare organizations have joined together in joint ventures and other types of collaborative arrangements. What are the forces that are driving this, and do you see more of these types of joint ventures and other collaborative arrangements in the future?
Yes, the answer is yes. I think the word of the day is collaboration. And again, as you look at creating networks, looking at your new models of care, doing population health management, having the geographical coverage to take care of that population wherever they may be living, you can joint venture, you can affiliate, you don't have to own everything to provide that full continuum of care. An example of that is occurring with our organization in North, where we are joint venturing with Tenet as a investor-owned system that we are taking 4 of their hospitals, 1 of ours, and putting together a joint venture to get geographic coverage in order to further our initiative around population health management. And so we'll own, for one of our facilities, 51-49, and the others will own 75-25. So we have 120 joint ventures. Collaboration is key, and so we'll see that. We joint ventured with USPI, which has now been acquired by Tenet. We started that with our ambulatory surgery. It's a capital preservation, and it's speed to market, and it's coverage. And as we get more and more constrained by the need for capital and the appetite, these collaborative efforts, look for more of them, I believe, to occur.
Couldn't agree more. HCA, I think, was one of the leaders over 20 years ago in establishing the very first hospital joint ventures in Austin with St. David's and in San Antonio with the Methodist healthcare system down there. That was something that was born out of, obviously, a lot of turmoil in the marketplace at that time. I think we see that same turmoil certainly today. And so you're going to see that. I think what we see across the United States is that you see a whole lot more of that activity around, I will call the periphery, the tangential services, and not necessarily the core hospital services. I think that is the last thing to sort of tip sometimes, Joel. But I do see a lot of that activity, and I would say there has never been a time in recent history anyway for HCA that we've had a more full pipeline of suitors and opportunities to look at joint ventures and to look at different, different arrangements with different players around the United States.
Yeah, I would say I think certainly in the urban markets, certainly in Texas, where they're financing, cash, sources to capital isn't as much of a driver. I think it's more, I think what Joel said, speed to market. And you can move faster together, and some systems are going to be stronger in some areas than others. And I think certainly even smaller systems sometimes don't even, not just in capital, but don't have executive talent and resources and some of the subspecialty physician, IT knowledge that you have to move as quickly as we're going to need to move in the changing healthcare market.
So I think we have time for one more question. But in the last few years, there's been a relatively rapid spread of and implementation of the concept of an accountable care organization, or ACO, and this, of course, has been helped along by the Affordable Care Act and some of the financial incentives from the Centers for Medicare and Medicaid Services. Do you think that the ACO is going to help achieve, or is helping to achieve, the triple aim of improving the patient care experience, improving the health of populations, and then also reducing per capita cost?
Joel?
I'll go, yes.
Go ahead.
Yes. Methodist was one of the first in the nation, the first group of ACOs after the pioneer group of Medicare shared saving ACOs, MSSP. And so we are in our 3rd year, and we've had 2 years of sharing savings with the government, with CMS, by reducing utilization of readmissions, ED visits, cost per Medicare patient. So it's been a benefit, I think, certainly for everyone that's participated early on in the ACOs, because it teaches your providers to work together. It helps you learn managing a population while you're still in a shared savings type of environment. I think where Medicare is going, certainly after these first 3 years, where commercial payers and everyone's going, is more shared risk, even further beyond ACOs. So I think the ACOs have been helpful in improving health of the population, reducing costs, helping us learn to manage our patients and work with other providers. But it will continue to evolve into an even more integrated type of healthcare network.
Let me give you an example to answer your question. Yes, I agree with Laura. And back before the Affordable Care Act in 2010, we cast at Baylor Healthcare System what we call Vision 2015, had 7 pathways to excellence. One of them was to create an ACO, or an accountable care organization, knowing that we didn't know what it meant. Nobody knew what it meant. You've seen one, you've seen one.
I'm not sure we know what it means now.
And it's it. So we studied it, we put together, and finally what we did create was the Baylor, Scott, and White Quality Alliance, is what it is. It was the Baylor Quality Alliance. And to Laura's point she's made earlier, the first cohort, the population, which really that population health is around the triple aim you mentioned, Ed. We said, let's prove we can do it with our own employees. We're self-insured as large systems are. And we put the employees and their dependents into that. We now have 2 years of experience of managing that population. We have reduced admissions 10%. We've reduced readmissions 11%, and we've saved $24 million off our base cost, which is about a 6% savings. We've now taken that to the market. We have 250,000 covered lives in our accountable care organization, one of which is a teacher system in Texas. They went out for a statewide network. They said, if you choose as a teacher to go with the Baylor Scott and White Quality Alliance, you have no out-of-network benefits. They will manage your care. And we have the stratification data to do that. If you stay there, you'll get full coverage. We thought about 2,500 in the north, 8 counties would sign up. 22,500 signed up, and we just got another 6,000 that have signed up. So again, people are looking for this accountable care. I think it will only grow because you're managing the health, working to reduce that 5%, and as Laura said, taking that 80% that only use 20% of healthcare dollar and keeping them from being a rising risk because you have good data systems around care management, around aggregation of data, and stratification.
Well, Laura, John, Joel, thank you very much.
Thank you.
Let's give our panel applause. Now, Dean Maness.
This has been a great day, and this is the last panel of our 2015 Leadership and Innovation Summit. And I have just really appreciated the panelists. Let's give this panel another round of applause, if you will. As we draw a closure, let me just provide a couple of concluding comments. I still think finance and accounting have something to do with what's going on, if you were here earlier. Speaking as the former chair of the finance department, there was some question raised earlier in an earlier panel. But just very quickly, there were 3 topics, and many of you, it looks like, I think, see a lot of faces that were at all 3 panels. But the business schools really addressed these issues in a number of different ways. The technology panel, key issues back when the dot-com bubble burst back in the 2000s, there were a lot of schools that disbanded their technology department in business schools or their MIS programs in business schools, and I applaud our department finding ways to maintain to be a viable program and I supported that because I just felt like technology is just too important to business and to society for us to turn our back on it just because there's a market downturn. And that's proven to be a positive outcome for us because we've been able to maintain our program. Matter of fact, we kind of doubled down. We not only maintained the program, but the university approved a PhD in information systems. And it was actually our first PhD program out of the business school. So technology is important to us. Energy is critical in the area of Texas, in the geography of Texas. And we have so many alums out in the energy industry that, and we recognize that as something very important for us as a business school. So we are looking at starting a certificate in energy commerce, just to better educate our students in the area of energy to help support them in turn, whether they go into banking or industry or whatever it is. If they want to get into the energy industry, we want to provide them a track to help them do that. So again, that's a very critical industry for us. And then healthcare. Several years ago, we recognized that Baylor's got a great name in healthcare. The Baylor Business School didn't have a single course or a single program in healthcare, and yet, what a critical industry. And again, we rallied some faculty together and started a program and had a lot of support from friends and alums of Baylor, and started a program in our MBA program that was a specialization in healthcare. And gee, this group supports that program through residencies and advisory board activity and these kinds of things. So that's just been a great thing. So the business school, these are some key issues that I just wanted to apprise you of as to how the business school is addressing these from our own standpoint to help provide leadership. And again, leadership and innovation. We keep trying to innovate programs to meet the needs to put students out there with the Baylor education. So I appreciate you. I would wager that if we did not have the Paul L. Foster Campus for Business Innovation, you would not have stayed here this afternoon if we had a summit, because this place makes you want to stay here and learn something. So you're acting just like our students do on Friday afternoon. They're here, they're collaborating, they're studying, and you did the same thing, so I appreciate it. Let's give a round of applause for all the panelists who participated in the program. I'll tell you what, we appreciate you. We appreciate Paul and his family. We appreciate you, the investors, the other investors in this magnificent facility called the Paul L. Foster Campus for Business Innovation. It will indeed revolutionize how we do education here at Baylor University. Thank you very much.